Good day, my dear postgraduate students. Welcome to Recent Advances 24. The topic for the day is the pathology of acute lung injury by William Wallace. These are the subheadings of which we will have to concentrate on the pathogenesis and the mediators. Coming to the introduction, this term has got different meanings in different special groups. In the sense, it is more of a clinical topic, and there is a spectrum of lung injury, including acute respiratory distress syndrome. The term was coined in the American European Consensus Conference 1994, and the diagnosis was based on the chest X-ray or the CT and the impaired oxygenation. They had to rule out any cause of a left atrial hypertension or a valvular stenosis because these, by back pressure, can lead to pulmonary edema. Of paramount importance was the ratio of arterial oxygen to inspired oxygen, and these are the degrees of severity. The term was introduced by this gentleman, Katzenstein, and he thought it to be an inflammatory fibroblastic process of the lung, in which there was a loose and an edematous granulation tissue, unlike the firm interstitial fibrosis, which can be a differential diagnosis. And in pathology itself, strangely, there has been a wide spectrum of happenings which has been missed by the clinicians. And this is our man, David Katzenstein, who died of COVID recently. He was from Stanford University. This is a wonderful picture that you people will have to go through. Thanks to Priyanka Singh. She is a wonderful cartoonist and a diagrammatist for the medical pictures. Look at this one. It is a case of a hypoxemia, and the heart is trying to do its best, in spite of which you find that there is not enough oxygen, and the oxygen supply to the various organs is severely reduced. For heaven's sake, give me oxygen. And there is an edema within the lungs, leading to the lack of oxygen. On radiography, there can be infiltrates found within the lung. So, bilateral pulmonary infiltrate, and in the absence of heart failure, you can use the term acute lung injury. This is a good diagram which I would like you people to kindly concentrate on. This is a normal picture that we are having. A normal alveolus, and then you have got the surfactant, the epithelial cells, etc. The type 2 pneumocytes. But on the other hand, there is something that is happening. There is an injury to the alveolus, sloughing of the bronchial epithelium, inactivation of the surfactant, and also there are the neutrophils and other inflammatory cells which are releasing a panel of mediators. I find that there is a leakage of the alveolar capillary blood into the alveolar space. Finally, there is the production of the hyaline membrane and the deposition of fibrin. Please do remember this particular one. This diagram is worth its weight in gold. Diffuse alveolar damage pattern is seen in ALI, acute lung injury, ARDS, as well as in COP, which means cryptogenic organizing pneumonia, and eosinophilic pneumonia. So look at the play of words that is over here. For us, it might be something similar, but then to the clinician and to the patient, it will be totally different because of the line of treatment. And these have been dealt with by the various societies, such as the American Thoracic Society, European Respiratory Society, etc. Etiology. It can be divided into pulmonary and extrapulmonary. There are subtle differences, and obviously a history will be of paramount importance. There is a stereotype or a stereotactic pattern of injury. Pulmonary and systemic sepsis can act as triggers. It is not inevitable, that is, it can be avoided, but then there are some host factors which can trigger it. Hence, they thought that genetics can be playing a role. And there are certain biological markers which can help them in making a diagnosis. Finally, interstitial pneumonitis can lead to respiratory failure. Etiology, this is very vague, but then look at this particular table. These have been divided into the direct or the pulmonary injury and the indirect extrapulmonary injury. And these are the list: pneumonia, aspiration of the gastric contents, contusion, fat embolism, drowning or near drowning, etc. Reperfusion. I shall be showing you a picture of it. On the contrary, there is indirect, something far away from the lung that can lead to this particular damage: sepsis, severe trauma or shock, cardiopulmonary bypass surgery. Do we ever know that cardiopulmonary bypass surgery can lead to ARDS, drug overdose, pancreatitis, transfusion of blood products? And these have been updated from the ResearchGate. This particular table I will be repeating n number of times. This is another source again from ResearchGate in which there are two columns. I would like you people to kindly memorize this particular one so that the etiology is taken care of. And incidentally, these are the stages of it: exudative, proliferative, progressive. This is standard. For example, in pneumonia, you have got a stage of congestion, stage of red appetization, gray appetization, resolution, or organization. So the same thing is over here. This is a super picture again by Priyanka Singh. See what is happening over here. There is a diffuse alveolar damage which can be direct or indirect. So the table that I had shown you earlier is replicated well. Direct injury, see the sources, it can be because of the gastric contents. Burning and saliva means there is a regurgitation. And then there can be a pneumonia or an infection, near drowning. Look at the way it has been depicted. Toxic inhalation, the fumes can be seen going into the lung, and a trauma with the gloved hand. Beautiful, superb. This Priyanka Singh has been contributing to a number of such ones. So I would like you people to kindly go back to this particular source and see how much you people can get hold of. Coming to the indirect, it can be pancreatitis, it can be sepsis, transfusions, etc. The indirect injury, what happens is there is a chemical mediator, cytokine storm, and also there can be fat embolism, amniotic fluid embolism, etc., which can be causing the damage. One lung ventilation. So what is happening is there has been a kind of a collapse of the lung, and then there is a reperfusion that is trying to be done. They try to inflate the lung. So when it is ipsilateral, there is ischemia, there is hypoxia. And there are the various mediators such as reactive oxygen species or nitrogen species which come into action, and they lead to cellular damage and cell injury. So when it is done on the same side, it is this. At the same time, the contralateral side also, it undergoes a hyperoxia, and there can be a hyperperfusion, hyperinflation leading to the damage. This particular diagram, I think people can draw. This is the source of reference for this. Again, a very simple picture worth its weight. See how it is being done. So on one lung, I am finding the normal alveolar cells, alveolar type 1 cells. There are the macrophages, epithelial basement membrane, surfactant is intact, and the fibroblasts are harmless. Whereas on the other side, I find that there is a sloughing of the lining epithelium. There can be an edema over here. The leukotrienes are being released from the neutrophils. Activated neutrophils, look at the panel of markers over here. I would like you people to kindly memorize at least some of the markers. As a result of which, finally, there is a fibrin, denudation of the basement membrane. Alveoli can also be having the macrophages, which again lead to the mediators. In another context also, I'll be showing you the importance of the macrophages. Finally, you find that there is a slough that is being formed and hyaline membrane is formed. So this is the alveolar capillary, there is a swelling of it, and you find that there is a leakage of the material. The fibroblast also gets converted. So it is worth repeating for you people. You will have to draw and write this. This I had prepared on my own. I would like you people to kindly do it. So the wonderful summary: a lung infection, aspiration, sepsis, trauma, other insults. All of this can lead to acute lung injury, in which there can be a capillary membrane injury, inflammation, permeability, and pulmonary edema. What will happen is there can be a resolution of the edema, or sometimes there can be a persistence which can lead to progression, and multi-organ failure can be occurring. Pulmonary fibrosis, vascular destruction, and finally death. So this is a wonderful one which you people can draw in the exam. The same thing is again being repeated. I need not go into it, but this picture is worth going through. So you find that there can be neurogenic, there can be ischemia, drug toxicity, non-pulmonary causes, then there can be pulmonary, such as infections, aspiration, so on and so forth. Direct and indirect causes of lung injury. Now, what are the various stages? Proliferative phase, 5 to 7 days from the onset of lung injury, and macroscopically, the lung is heavy, gray, consolidated, firm. Boggy can be a better word. So I can see it. I need not weigh the lung to know its weight. So it is almost liver-like. And probably if I compress it, there will be some amount of exudate coming out. The basement membrane is disrupted, myofibroblasts proliferate into the interstitium. And there is a break in the alveolar basement membrane leading to exudate. So this is a source of reference for it. And finally, there can be proliferation of the type 2 pneumocytes producing a hobnail pattern. The problem with this is they will be having a cytological atypia, pleomorphic nuclei, and punctuate nucleoli. So when there is going to be a bronchoalveolar lavage, it can be mistaken for a malignancy. And this is the source of this particular gross specimen. And this is another one. This is from pathology outlines. So macroscopically, it may appear normal or it can become edematous. And in autopsy patients, you find that the lung is heavy, red, beefy, boggy, firm to palpate. In fact, if no history is given, I might well mistake it to be a liver. And I find that there is some kind of nodularity and a septate that is being formed. So that is why we get the word hepatization, because it becomes liver-like in consistency. And look at the electron microscopy. There is necrosis of the alveolar epithelial cells, denudation of the basement membrane, margination of the neutrophils from the alveolar blood vessels. Please remember this. These are almost superimposed, not very difficult for us to recollect. The exudative phase continues. 2 to 3 days later, you find that there can be apparent edema. There is a hemorrhage rich in fibrin. Alveolar spaces show necrotic debris, and the fibrin condenses, producing a hyaline membrane. Alveolar and the interstitial inflammation are not very conspicuous unless there is a superadded bacterial infection. So it is more of a hypersensitivity like thing, or because of the cytokines, rather than an actual infection and inflammation. So this is the serological analysis, the reperfusion. What happens when they actively try to reperfuse the lung that has collapsed? You find that there can be an edema. These black areas are areas of edema. At the same time, there can be a break in the alveolar septate producing an emphysematous change. I find islands of parenchyma between sea of air. This is from Wikipedia, in which there is a hyaline membrane, there is an exudate that is being formed, congestion of the capillaries is over here, and there are a few inflammatory cells. The main trick here will be the hyaline membrane. which is pale, eosinophilic, acellular, lining the alveolar space. Then there is a fibro-proliferative phase, the migration of the myofibroblast into the alveolar spaces along with the exudate. There is proliferation, deposition of the extracellular matrix, and these all form a loose granulation tissue. This particular word has been repeatedly emphasized upon. Whenever we think of fibrous tissue, it is firm and it forms a network so that it provides support. But in this case, it is more of a granulation tissue and fibrosis. And they say that the myofibroblast, etc., may be from the alveolar stem cell. And it is an attempt at healing rather than the pathology itself. Again, a picture of it. So this is a collapse of the lung, an atelectasis. These can be the reasons, such as a surgery, reperfusion, trauma, etc. And what happens is when it is being ventilated, there can be the volume trauma, biotrauma, oxidative stress, etc. So in all these, you find macrophage activation, and there can be recruitment of the neutrophils, leading to acute lung injury. And these are some of the mediators, whichever you are comfortable with, interleukins or the cytokines, etc. Cyclooxygenase, I would like you people to kindly bear in mind. A simple diagram like this will help us. This is the airflow, this is the alveolar septae along with the capillaries, and this is the yellow one is the interstitium. Finally, you have got the fibrotic phase, wherein there are two kinds of changes. One will be a collapse of the alveolar architecture. So the alveoli are reduced to slit-like spaces, or sometimes they can produce nodularity, and a honeycombing can be seen in radiology. Nodular or alveoli can be cleft-like. In addition, histologically, we might see squamous metaplasia, secondary inflammation, and vascular hypertrophy. And in all this, they say that resolution is more common than fibrosis. This is a fantastic picture that has been taken by this particular reference. It is from a 22-year-old male. The history is given here, and the reference is also over here. What I would like you people to kindly see is the kind of the congestion that is seen radiologically, and there can be some kind of a network and a honeycombing that is being formed at the base. It is bilateral. Also, see this particular one. This is another one. There is a bronchiole over here, and these are all the interstitial areas in which there is a proliferation of the fibroblasts. Here there is a palisading arrangement. If a slide is given, I would suspect a schwannom. So that amount of fibrosis over here, and it produces a nodule. So this is a lung, maybe some amount of emphysematous changes. There is an edema of the interstitium. All these have been well explained by pathology outlines. Kindly go back to it. Look at the number of nodularity in this. In the fibro-proliferative phase, there is a migration of the fibroblast into the alveolar spaces, deposition, angiogenesis can be there, and there is a loose granulation tissue. Proliferation of the type 2 pneumocytes. This is a kind of repetition, but then it is worth it. There are some matrix proteins such as fibronectin, tenascin, and collagen 3. And finally, you find that there are certain factors which are derived from the macrophages or platelet-derived growth factors, then insulin-like growth factor, etc. And these can be again some of the mediators which are being produced. This we have already seen. Look at this one. A very fantastic honeycomb-like picture that is seen. Beautiful honeycombing, as though it is a bee's hive. What is the difference between a fibrosis and a resolution? It is almost like complete wound healing and a scar. Regulation of wound healing can be studied. It is usually seen in tissues such as the skin. In the lungs, the collagen actually impairs the function, because once there is a fibrosis, there cannot be exchange of air across. There is a cessation of the inflammatory process, and there is no proliferation of the epithelial or the endothelial cells. And two morphologies you people should remember. One is an interstitial fibrosis. You get a skeleton-like framework of the lung. Or you can get collapsed slit-like spaces. This is the role of the macrophages. I would like you people to again go through it. This you can apply in the role of macrophages in health and disease also. Look at this one. There can be an alveolar edema. It leads to clearance. There can be a sealing at the junctions over here, promoting angiogenesis. Phagocytosis, of course, is its property. It can inhibit the neutrophils. It says, I have come, now you have got no role to be here. And ultimately, there can be a protein-rich fluid which can be produced, and there can be an edema. So this is one showing the role of the macrophages. This is a review article. You might not be having time to go through it, but this one have in one corner of your mind. You can apply it for the role of macrophages in health and disease. And what is the pathological diagnosis? Usually a pathological assessment is not required. It is essentially a clinical diagnosis. And the lavage samples for infective organisms can be the diagnostic cytology. But I mentioned the pitfall. There can be atypical appearance, prominent nucleoli, making a suspect malignancy. Regenerative epithelium can be showing this atypia. And what can be this? Pathological diagnosis. Lung biopsy is not routinely performed. And the differential diagnosis can be organization in a case of a pneumonia or other connective tissue disorders. The fibrotic balls, one can suspect a silicosis also, infection, drug reaction, malignancy. And there is no inflammation or hyaline membrane that is seen in a case of malignancy over here. And these are the differential diagnoses we have mentioned earlier. I am not going to go into it. Vaginous granulomatosis. Look how vast the spectrum is. And radiopathological correlation becomes mandatory. At hospital autopsy, ITU was given. I do not know. Probably is it intensive trauma care unit or thoracic unit? I do not know. ICU is something we all know. There is a respiratory failure, fibrosis can be there, culture can be negative. And ventilator associated pneumonias can also develop in the patient. And these are the things, patchy interstitial and then heterogeneity. Sometimes there can be a honeycomb appearance or a compression. And now, dear students, what is the summary? What is the essence? Please remember, it is a complex clinical problem, not basically pathological. 40 to 50% can be resulting in mortality. Supportive management is needed in the case of diffuse alveolar damage. And you find that fibrosis can lead to either resolution, loose fibrosis, or sometimes it can be progressing to form the fibrotic balls. And that will be most common. These terms I would like you people to kindly rehearse and find out. Kindly find out the meaning and the origin of the word that you see on the screen. Thank you.